unfortunately been born with a cataract, so a congenital cataract. So cataract surgery, as I said, very, very common operation, is basically where through some micro incisions, some small cuts at the edge of the cornea, we basically are able to get to the lens, which is covered in a capsular bag. And so the operation involves basically making a circular hole in the capsular bag and then releasing this cataract, this lens, which is clouded, from the bag by doing something called hydrodissection, and then breaking it up with this machine called a phaco machine and removing all of it, removing the outer sort of layers of it, and then putting the new lens in. And so many people, often patients, will say to you, "Are you going to be using a laser, doctor?" And of course, it's actually phacoemulsification that helps to break up and hoover up, I guess, the bits of the broken up cataract, and that's ultrasound energy rather than a laser, as it were. Of course, lasers are often used to assist in cataract surgery, but it's phacoemulsification and not specifically laser surgery for the whole. And of course, once you've had your cataract removed, some people will develop posterior capsular pacification, which is basically where the bag, which is a bit like cling film, which holds the lens, the natural lens in place, and then eventually holds the artificial lens implant in place, just as you see here, becomes clouded up. So I guess it's a foreign thing that's in the bag, a little plastic lens implant, and you get sometimes a bit of a reaction. So younger people, people with a strong inflammatory response, are more likely to get posterior capsular pacification. So it's kind of 100% of congenital cataracts. In fact, many surgeons will do something called a primary capsulotomy during the operation, because they all develop capsular pacification. But in an adult, this is easily dealt with a laser treatment called a YAG capsulotomy. So moving on to another very common front of the eye condition, we have glaucoma. Now, glaucoma, broadly speaking, can be classified as open angle or closed angle or narrow angle glaucoma. But we're going to deal with open angle glaucoma first. And glaucoma is essentially a triad of raised pressure, which causes thinning of the optic disc at the back of the eye and loss of nerve fibers, and then eventually can then lead to loss of vision, usually peripheral vision, so field defects. And because open angle glaucoma is where you have raised pressure usually, but not so massively high, you don't necessarily feel anything. And so you may be very gradually losing vision, your peripheral vision, which isn't in your line of vision, and you may not know it at all. So screening for glaucoma is something that's quite important, and most opticians will check a pressure, every time you go and see them, and sometimes do visual field tests. So risk factors, as you can see here, family history, being short-sighted, tends to be more common in the Afro-Caribbean race, but of course anyone can develop glaucoma. So pressure is checked in the eye with applanation tonometry, where we touch the front of the eye, and of course pressure is force over area, and with a bit of fluorescein dye on the eye and a little bit of something to numb the surface of the eye, like proximethicane, you can basically use this very simple technique to check the pressure. But there are many other ways that you use puffs of air, like you do at the opticians. This is Goldman applanation tonometry, which tends to be regarded as the gold standard way to check pressure. And here's an example of a thinned out optic disc. So you can see the rim has thinned out. And this is an example of a typical glaucomatous field defect, which we often will call an arcuate scotoma, because it's like an arc and it's, a scotoma. So glaucoma is treated usually first line with drops. And drops have come a long way in that we have a wide variety of drops that work in different ways. If we think back to the pathophysiology of glaucoma, it's, of course, where pressure is building up. And the pressure is building up because if you think about the eyeball, it's a closed ball. And inside the eyeball, we have fluid that's constantly being produced. Does anyone know where in the eyeball, if you're thinking about your eyeball anatomy, where is this aqueous humor, this fluid constantly being produced? Anyone know where it's produced? Which structure produces the aqueous humor?
We've got lens area, ciliary,
Yes.
ciliary body.
Yes, that's right, ciliary body. So, yes, aqueous humor constantly being produced by the ciliary body. And where does it drain away? So you're right, absolutely right. It's constantly flowing through the eye. Where does it then drain? It comes through the pupil into the front chamber of the eye. And where does that fluid then drain away into?
We have Schlemm canal.
Yeah.
Schlemm, yeah.
So there's this kind of like, I guess, net-like structure that's on the edge between the cornea, the front window of the eye, and the iris, and it's called the trabecular meshwork, and that leads to Schlemm's canal, and then it goes into the episcleral vessels. So anything that's blocking that, making it tighter, will mean that pressure can sometimes start to build up, and that sometimes just happens as we get older. I will get onto angle closure glaucoma, which is basically where the channel gets kind of quite acutely blocked up. But yes, in addition to drops, of course, there's microscopic surgery, which has, again, in recent years changed a lot. So there's many different stents and things that glaucoma specialists are inserting into the drainage pathway to help assist with increased drainage fluid out of that anterior chamber so that pressure doesn't build up. And then the more traditional operations of trabeculectomy, where a new drainage canal is kind of created, and then tubes, because of course with many patients they've got such strong inflammatory responses that they continue to scar, and so a tube implant may be kind of a sort of step down the road where other treatments have failed or are just not going to work. So I know that you've had a lecture already on the red eye, so I don't want to spend too much time on this, but I'm just going to hopefully jog your memory and do a little bit of a recap and some common things. But when we think about red eye, I think the most important thing is actually the history before you even seen a patient. That will often give away, what the diagnosis might be. So, for example, if there is a discharge, what are you thinking about? Anyone?
Bacterial conjunctivitis?
Yeah, so a bacterial conjunctivitis may be an obvious, most likely thing. It could be something else, but of course, if they say they are a contact lens wearer, what might you be worried about?
Uveitis.
A corneal ulcer. So, if you wear a contact lens wearer, there's always that tiny risk of a scratch underneath the eye leading to an infection because contact lens is covering that, and so we always worry about contact lens related ulcers and so on. But yeah, I mean, obviously, if you've got something like photophobia and maybe your vision's not as clear and the eye is very red and achy, then maybe something like uveitis might be something you might think about. So subconjunctival hemorrhage, often seen in general practice, often seen in A&E, looks dramatic, but really usually nothing to worry about. But in patients where they are getting a recurrent subconjunctival hemorrhage, or there may be some concern, you might want to check their blood pressure, maybe take a history. Have they been coughing and straining or something like that may have led to a tiny capillary in the conjunctival tissue bursting and leading to this very dramatic but very risk-free usually problem. Looks bad, but really usually disappears on its own with time. Conjunctivitis, we've touched on this. I don't want to spend too much time on it, but of course, when you're looking at a conjunctivitis, you kind of want to think, is this infective? Is this allergic? Or is this kind of inflammatory? And if it's infective, is it bacterial or is it viral? And the typical things with bacterial, as we said, is sort of stickiness, sticky discharge. And, obviously it may come from the history. Maybe they've been around somebody else that had a bit of a bacterial conjunctivitis. And it is, of course, through touching, and we touch our faces and our eyes all the time. So we don't realize it, but, things spread very, very easily and is treated usually with antibiotic drops. Is something less commonly seen, but, needs input quickly. And in neonates can be, transmitted at birth and can lead to corneal perforation. So important to consider. Viral conjunctivitis tend to be much more watery, whereas the bacterial ones tend to be more sticky. And viral ones are usually self-limiting, but can be pretty bad, leading to really, really swollen eyelids and very, very chemotic conjunctiva, chemosis being, of course, where the conjunctiva has swollen up. So usually, as I said, self-limiting, but patients need to know that it is usually very, 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 because it's so watery, very, very contagious, and often comes from your own upper respiratory tract infection that then led to conjunctivitis. Typically, with a viral conjunctivitis, you'll get follicles, and you'll get that also sometimes with things like a hepatic conjunctivitis, which is also viral. But bacterial conjunctivitis tends to give you papillae, as does allergic conjunctivitis. So just signs like this will help you figure out what this is likely to be. And I'm conscious of the fact that you've already talked about red eye, but here's just a kind of, look at other conjunctivitises, which are important to consider as well. And episcleritis you probably heard of, which is, of course, a bit like inflammation of the outer layer of the wall of the eye, which can be quite achy, is usually self-limiting and may benefit with patients that are getting it, and it's staying with some non-steroidal anti-inflammatory drops, or sometimes just lubricants will just help to settle that down. So often an eye that's sort of red, you haven't had much sleep, you might be a bit run down, you might get a bit of episcleritis, and usually it is self-limiting. But for some people that are getting it, and especially if it's with something like a nodule, or it just is a little bit more inflamed, you might also want to think about associations. So things like if you're getting inflammation of the outer part of the wall of the eye, or the more deeper layers of the wall of the eye, which we'll refer to in a moment as scleritis, then you might also want to think about other associations. So, for example, rheumatoid arthritis or other autoimmune inflammatory things that also then manifest as wall of the eye wall pain, or eye wall inflammation, as it were. So scleritis, as we see here, is more deeper inflammation of the wall of the eye, and is more often associated with rheumatoid arthritis, and can lead to thinning of the sclera when recurrent, and sometimes needs more than just non-steroidal anti-inflammatory drops, but sometimes steroids in the form of drops or even tablets. So somebody's already mentioned uveitis, and the uveal tissue, as is demonstrated here, of course, goes from the front to the back of the eye, starting at the iris, through the ciliary body and the choroid. All of this is part of your uveal tissue, and depending on which part of the uvea is inflamed, will tell you which part of the eye has a uveitis. So it can be an anterior uveitis or iritis, or the middle part, or the vitritis, or a choroiditis, and if the whole of the front and the back is inflamed, maybe a pan-uveitis. So often when it's not affecting the actual retina, we'll say it's sort of an intermediate uveitis, but when it is affecting the choroid, the retina choroid, we'll say it's a posterior uveitis. Most times it is an anterior uveitis, and this talk's really meant to be mainly focused on the front of the eye. And usually this can be treated with drops. So I think somebody's already alluded to this, but if you can tell me what you think about some of the common symptoms, and I think I've already mentioned some of them, of an anterior uveitis, what might you think of that when you see or hear a patient's history? What kind of things might they be complaining of?
Would there be irregularities in the pupil size?
Yeah, you might see that. So that's obviously more examination. But in the history, what might they say?
Maybe they have like problems with seeing light, like it triggers them to have discomfort or pain.
Absolutely. So photosensitivity. Sometimes, if there is a lot of inflammation in the eye, you're going to get some blurring of your vision. Often the eye feels achy. Sometimes the ache, it kind of, the uveal tissue is very, very sensitive, and so you can get a bit of a headache. So yeah, all of those things, and it's red. It may be blurred, as I said, and you're absolutely right. Sometimes, in addition to this ciliary injection, which we see here, we often refer to this when it's all the way around. We've got this sort of like sun rays all the way around. We'll say this is circumcorneal injection, and sometimes you get these little precipitates from just a more diffuse layer of keratic precipitates. But you can get little dots on the back layer of the cornea, the endothelium, which are precipitates of inflammation, of inflammatory cells. And then you're absolutely right, this irregularity of the cornea, because when the front chamber of the eye is full of cells and inflammatory stuff, it makes it sticky. And so sometimes the pupil will then stick down, and that irregular cornea is definitely an important giveaway sign to be aware of. If it's really inflamed, you might see this, which we refer to as a hypopion. So this thing where you've got cells that have settled, this is a hypopion. When else, so this is an inflammatory hypopion in acute anterior uveitis. When else might you see a hypopion in the eye and might even be actually even more worrying? Anyone?
Is there like a bacterial infection? It's because it's pus, right? Hypopion.
Exactly. So a hypopion, which is exactly pus, it could be present, for example, in a contact lens wearer that's then got a bacterial ulcer that's really bad, led to inflammation, a uveitic, an infective inflammatory uveitis that's then led to a hypopion. What about if you've just had cataract surgery a couple of days ago and you come in with a hypopion? What might be what you worried about then? Anyone?
Maybe infection, doctor?
Yeah, infection. And we call this...
We had a patient yesterday who came for chloramphenicol after surgery. So probably due to not having antibiotic or due to post-surgery infection.
So the history in this situation, if you see an eye that has a hypopion, the history is really crucial. If somebody says they've had cataract surgery 2 days ago, they come in with a hypopion, this means they've probably got endophthalmitis. Endophthalmitis is where the inside of the eyeball is full of infection, and it's actually an emergency. So this is quite interesting because you're seeing a picture of a hypopion. In this case, we're referring to it in relation to acute anterior uveitis, and you would always want to dilate this pupil up and make sure that the back of the eye isn't particularly inflamed. And if it is, then it's an intermediate uveitis. If the retina choroid is also inflamed or has other stuff going on, then you might be thinking this is a pan-uveitis or a posterior uveitis. But if somebody comes in with a history of having had a cataract or any sort of intraocular surgery where somebody's cut into the eye to do something, then this could be an endophthalmitis, and this is potentially blinding and would require for the eyeball to have a sample taken from it that day, ideally, within the hour, within a couple of hours, and then antibiotics injected into the eye, into the back of the eye. And that sort of patient would be started on, hourly drops and would be monitored very closely, and unfortunately would be at significant risk of permanently losing their vision. So this picture, is a different presentation depending on the history, in that, you would take it, extremely seriously if they have had any intraocular surgery. If they're a contact lens wearer and it's the front part of the eye, serious infection, that's also serious. Hopefully you can treat it really, really aggressively and get rid of the infection, but it may mean that you probably see an ulcer on the surface of the cornea as well. So, there'll be, you'd see it, you'd understand it from the history, but just something for everyone to just remember, whether you are an ophthalmologist or not. Hypopion is something that we need to take seriously and understand what's happened in the history. So with anterior uveitis, you do want to see them quite soon, and you do want to treat it quite aggressively with usually topical steroid drops, and sometimes they can get pressure rises as well in relation to everything being so inflamed. Sometimes the pressure can be really high, and sometimes the pressure can actually be low. So important to monitor that. So as I know you've already had a kind of red eye talk, I don't want to spend too much time on this, but I think we've covered most of this. So moving on is another front of the eye thing here, a dendritic ulcer. I'll just show you. I think there was a picture, it's gone, but anyway, you see a kind of, I guess it looks like lightning on the cornea. And again, this is all about the history. So if they've got a history of cold sore virus, and you see a staining on the cornea, and they've got a red eye, and they've got pain, then you should really be thinking about herpes simplex. And herpes simplex in the form of a dendritic ulcer is a surface of the eye, a corneal issue, which can lead to scarring and means that, once you've got herpes virus, it can always come back. So it's something that patients need to be aware of. And, it's things like making these sorts of diagnoses very important, because for similar conditions, for example, you might want to use steroid treatment, steroid drops, but in the case of a herpes simplex dendritic ulcer, you wouldn't want to, especially not initially, not without having antiviral cover first and looking to hopefully heal that ulcer. So a dendritic ulcer, when you've got it in relation to herpes simplex virus, can then also lead to inflammation in the eye in the form of a herpes uveitis. So I said I'd come to angle closure glaucoma. So I guess this is also a presentation of acute red eye. And here we have the ciliary body that produces that aqueous humor, and the aqueous fluid then drains, as we said, into the trabecular meshwork and then into Schlemm's canal. And in acute glaucoma, it's different from open angle glaucoma. It's usually, in fact, let's see, can anybody tell me what the mechanism of acute angle closure glaucoma is? I mean, it says that there is occlusion of the angle, but who typically gets acute angle closure glaucoma? Does anyone know?
Is it the elderly, like mainly elderly patients? Some patients maybe trauma.
Why do you think it might be mainly people who are older?
Because they get weakening of the area in general, and they can be at risk of blockages and things of that nature. So it's like part of aging.
So not so much because of things becoming weaker. The reason is actually because, as we mentioned at the beginning of this talk, one of the things that happens as we age is our lens forms a cataract. And as it forms a cataract, what it does is it becomes thicker. Now, if an eye is already small, what can happen is as the lens starts to become thicker, it starts to push the iris forwards. And that angle between the cornea and the iris is key to enabling drainage to happen. So whereas an open angle glaucoma, as you age, you might get sort of mini blockages along the trabecular meshwork that might lead to open angle glaucoma. An angle closure glaucoma, it's a different process. What's happening is that this lens here is becoming fatter. It's pushing the iris forward, and this angle is closing, and quite literally, fluid is continually being produced, and it almost can become a vicious cycle, because what can happen is this lens reaches a kind of threshold where it's basically causing a buildup of pressure. But the buildup of pressure then starts to occur even behind the lens and tends to push the lens forward even more. And you get something called pupil block, where the lens is touching the iris all the way around, and fluid can't even get through eventually anymore. And you've got this massive buildup of pressure. It's like this vicious cycle, which is acute. And typically what you often see is your little, often old lady, actually, who has been sitting in the dark in the evening, because what happens when we're in the dark to our pupils versus in the light? So obviously in the dark, our pupils are dilated, and in the light, our pupils constrict. And so it's often in the evening, in lower lighting, that pupil is dilated, that lens has reached this threshold where it's thick. And it's basically means that the angle closes more easily when the pupil is dilated. So, as we've said, it's often in people who are older, and it's an acute problem. And often Asians, Orientals, will have smaller eyes, so sometimes it's more common in that population. And typically you'll get, the patient that comes in having been in a lot of pain. And unfortunately, sometimes it's patients who, they don't want to worry anyone, so they might sit on the pain for a while. And because it's this vicious cycle, they end up coming in with extremely high pressures, sometimes in the morning, so they've sat on it all night and they've developed acute angle closure glaucoma, and the pressure's really high, by which time, because it's so high, they feel sick, they're vomiting, their eye is red, they feel awful, and their vision is blurred. And so, you know, this is a sick patient, and I guess, you know, if you know not much ophthalmology, one thing you do need to be able to sort of think of and recognize is angle closure glaucoma, because it is sight threatening and can be treated, if treated promptly, can save vision. So because the cornea is a normally clear structure, when you've got pressure against it constantly for hours, what happens is it shuts off those endothelial cells of the cornea, the back layer of cells, which are constantly pumping water out as the cornea becomes edematous. As I said, you get this pupil block, and often the pupil will be sort of fixed and semi-dilated, and the pressure will be high, and the anterior chamber, when you look at it on a slit lamp microscope, will be very shallow. So they need to be treated with various drugs to lower the pressure, and, you know, antiemetics and analgesia are also something that we shouldn't forget about to help manage this patient that's really not having a good time. So moving on, contact lens problems. We've mentioned these already. You know, if somebody has a contact lens wearer in the history, especially if they've said they've slept in their lens or showered in their lens, you know, not good signs. I know that sometimes we have contact lenses that are sold as day and night lenses, and whilst, you know, for the most part, people who are sensible will be okay, they do pose a much increased risk of infections that lead to ulcers that can lead to visual loss. And when you've got a big ulcer on the center of your cornea that's in your visual axis, even though you might be able to, you know, treat it and it heals, they may end up with, unfortunately, you know, reduction in their vision because of a corneal scar. So this is something we want to treat quickly before it escalates, and treat aggressively. This is that picture of the dendritic ulcer. Apologies, in the wrong place. But here we are, our snowflake or lightning-like ulcers. So just really, this picture is just so that we can have the chance to recognize this very typical-looking ulcer that, you know, should lead us to be asking about cold sores and cold sore virus and the history, and treat it appropriately. Not with steroids, but with acyclovir or ganciclovir or an antiviral cream that you have available. So I'm going to move on now to some eyelid problems. Are we doing okay for time? Yeah. Okay, so eyelid problems. We've got common things. This is a chalazion, which is a blocked meibomian oil gland, which leads to, I guess, a boil, as it were, under the eyelid. Many people will think that these are infections, but actually they're not. You know, they can become infected, and if they become infected, then we would say there's a cellulitis. But for most people, if you do lots and lots of hot compresses when they first come, when they first start to occur, usually we can get them to resolve spontaneously by coming to a head and then discharging their contents. So that should be the first line of treatment. Sometimes when hot compresses and massage fails to get the chalazion to come to a head, then draining it surgically may be another option. Sometimes we even inject steroid into them, which will help to reduce the inflammation. Because if you look at if you were to look under the microscope at what the stuff is that's inside the chalazion, it's all lipogranulomatous inflammation, because meibomian oil glands, of course, are oil glands, and when they become blocked and really inflamed, you've just got this mixture of inflammatory and oil material. So here's an example of where you know, a chalazion may have led to a preseptal cellulitis. So especially in kids, we want to treat this quite promptly with oral antibiotics. And I say in kids because the structures, the sinuses and the communication between the sinuses, the orbit and the sinuses and the brain is just much more, is thinner and is more easy to penetrate. And so in a child with a chalazion or something else that may have caused a preseptal cellulitis, that can quite quickly lead to infection spreading behind the eyeball. What do we call where you've got the front of the eyelid infected? We say it's preseptal cellulitis. When it's the eye all the way around the eyeball, what do we say it is then?
Periorbital?
Yeah, exactly. Periorbital, orbital. And orbital cellulitis is basically, how would you know somebody, what kind of things might make you think somebody's got an orbital cellulitis? I've sort of given it away a little bit when I've asked about the history.
Is it not the lower and upper lid both are affected, doctor?
Yeah, here it is actually, but apparently, I mean, this may be leading to an orbital cellulitis. Like, the way to know is by getting them to look left, look right, look up, look down. Once the eyeball starts to be painful to move around or restricted, which is of course even worse, then you're definitely worried about an orbital cellulitis. When the eyeball is possibly even pushed out, that might suggest that, you know, when it looks proptose, that may suggest an orbital cellulitis. When there is a pupillary problem, you know, so the pupils aren't reacting anymore, or the vision's down, or the color vision's down, these are all things that you would check to see if there's any sign of even an early orbital cellulitis. And if you thought there was, then rather than just oral antibiotics that you might give for a preseptal cellulitis, you might be thinking about IV antibiotics and maybe admitting them, because things can progress quite quickly, especially, as I said, if they are a child. So here we are, orbital cellulitis. And sometimes it's not always a chalazion, it's not always external trauma. Sometimes it can be actually from the sinuses. So somebody that's got a propensity to sinusitis and maybe develops a bacterial sinusitis, and that infection then spreads through the ethmoidal sinus or the sphenoid sinus into the orbital compartment. You can then very quickly develop reduction in vision, but this is going to be a red eye and a proptosed eye potentially, and an eye where the eye movements are possibly restricted. These patients may need somebody's got their hand up.
It was just a question about the orbital cellulitis with the picture you were showing. Does the orbital cellulitis, can that lead to the meningitis, or is it meningitis that leads to orbital cellulitis?
More likely, I mean, I guess infections can go both ways, but more likely that you can get. So what can sometimes happen with an orbital cellulitis is it spreads into. You can get a subperiosteal abscess, so into the bone, and then you can actually end up with a. I've seen a child before I've seen actually a few patients before where they've had an orbital cellulitis, and very quickly it's led to a frontal abscess in the brain. So maybe not so much meningitis, but an abscess that then spreads into the brain tissue is definitely something that can and does happen if not treated promptly. So yeah.
Thank you, Doctor.
Okay, so another example of herpes, but this is of course shingles. This is herpes zoster, often in the elderly, and often these patients are really run down, or they're older, and they're more likely. All of us, of course, who have had chickenpox have herpes zoster inside us, and if our immune system is down for some reason, then we may develop something like shingles. If you see a patient that's 25 years old, and you thought they were well, but they've developed shingles, what other things might you be thinking about in terms of their general health? Immunity. Yes, exactly. So, is there something else that's underlying that? And if you might even be thinking about other other things that may lower their immune system, and sometimes even things like HIV, exactly, or other. How are we doing for time? 47:43. Are you okay? Is it all right for me to continue? Are you guys okay with that? Or did you want to stop now for questions? I'm just conscious that we have a little bit more to go.
We've only had a couple of questions, to be honest, so I think you're able to continue. Yeah, of course.
Thank you. So I just wanted to quickly, as we're talking about the front of the eye, do with a bit of front of eye trauma. And so here, we've talked a bit about the cornea, and of course the cornea can be scratched, and it can be scratched by a contact lens, but also just by things. Often people will come to eye casualty with a red eye that's painful. They might have a history of, they were walking in the park and they walked into a tree branch or something, or, the very common one, you've got a toddler who pokes you, or something like that. So, these are common, and we see them all the time. And it's not just in ophthalmology, but in main casualty, patients come in and the casualty doctors will put a bit of fluorescein dye in the eye, and that will stain up that epithelial defect. And usually you can treat these with just some chloramphenicol ointment. The cornea has more nerve endings than any other part of our body in concentration. And of course, for good reason, because it helps us to protect ourselves. But of course, that means that pain can be excruciating. So a tiny corneal abrasion can feel awful. But the good news is that the cornea epithelium is regenerating constantly, and often an abrasion will have healed within a few days. Sometimes if it's a biggish abrasion and you feel that patients are just not going to cope, you might put lots of chloramphenicol ointment in and then pad the eye and get them to take the pad off the next morning. You wouldn't want to keep it padded for more than 24 hours, because the last thing you want is a potential infection to be kind of incubating under there and getting worse. But, managing the abrasion, if you think it's just a corneal abrasion that's not infected, you may choose to do that. But of course, the history is always important. Is there something else underneath the eyelid, for example, that's caused the abrasion? So you want to always check and ask. Chemical injuries. Now, chemical injuries will often come to main A&E, and sometimes it will be associated with a more facial chemical injury. Alkali tends to be worse than acid, because alkali will continue to penetrate often for 48 hours after it's hit the eye. So something to be important. Often you get these plasterers that have been plastering the ceiling, and a bit of plaster's got under their eyelid. So always evert the eyelid. If there's any little bits left under there, they need to be fished out, because, the alkali in the chemical will continue to penetrate and cause harm. So chemical injuries can be really mild, but sometimes can be really, really severe. And here's an example of a more severe one that's led to a massive corneal scar. And unfortunately, in this sort of situation, a blinder unless they get a corneal transplant. Foreign bodies, very, very common. Often, you'll get the foreign body that's from a bit of metal that will have rusted very quickly, because of course it's a very liquid environment with your tears covering, your ocular surface all the time. So this will obviously often be obvious from the history. And you want to also, as I said before, check under the eyelid that there isn't anything under there that may then cause another scratch or another foreign body. So here's an example of a rusted corneal foreign body, very typical of a common thing that we would see in eye casualty. Moving on, we have, now this is obviously not strictly speaking front of the eye, but often you'll see some signs at the front, just looking at the front, I guess, of the eye and the face, because an orbital fracture is sometimes a blowout fracture. So you might see an ophthalmic eye, where basically the eyeball is pushed in. Why do you get reduced periocular sensation? So why might you, sort of when you touch here, why might their sensation be less than on the other side that hasn't had the blowout fracture? Anyone?
Is it because of the crossing over of the nerves?
It's just due to the infraorbital nerve and its pathway, and so it just happens to come out through here, and basically, if the bones have been compromised, the bony structure that houses your eyeball, then that's a sign. So you might see that reduced sensation, and that might be one of the many things together that prompt you to get some imaging for a patient. Why might you get decreased ocular motility?
Could it be like a lesion, like a neural lesion, or like a weakening of the actual muscle itself? But
basically, it's a mechanical thing. If you can imagine, you've got your orbit, your orbital bones. The orbital rim is actually very strong, and so it would take a lot to fracture the actual orbital rim. But the bones that actually surround the orbit, of them, the floor of the orbit is the weakest, and the nasal part, the ethmoidal part, and so those are the bits that will tend to buckle under the pressure of, I don't know, big football hitting the eye, or tennis ball or something, or big punch by somebody in a fights or whatever. And so you get this fracture where the bones have obviously fractured, and so that can lead to entrapment of soft tissue, or worse, extraocular muscle. So if the inferior rectus muscle is stuck in the fracture, which direction can they not look in? Anyone?
Can you repeat that? Sorry.
Yeah. So if you've got, if you can imagine somebody has trauma and they've got an orbital floor fracture and they've got a bit of the inferior rectus muscle stuck in the fractured hole, as it were, that's going to restrict their eye movements, isn't it? Which way do you think they're going to have most restriction?
I think that's down, inferiorly.
Yeah, it's actually up, because it's mechanical. So you're right. I see what you thought. So the inferior rectus muscle obviously helps you to look down. But I guess the inferior rectus muscle would still be working if it wasn't stuck. So you might still be able to look down a bit, but you definitely won't be able to look up because the eyeball is just stuck in that position, if that makes sense. But you get some restriction in all directions of gaze, but probably most of all in up gaze. Anyway, so with this sort of patient, you basically want to make sure that that you've covered them with antibiotics. If there is muscle entrapment, then they'll probably need some surgery quite soon, because the last thing you want is a muscle that's trapped to become ischemic. If they've got some movement, but there's just some soft tissue swelling that's in the fracture, then you may be able to watch them. And sometimes these orbital fractures are repaired a few weeks afterwards, and sometimes they're not repaired at all. It all depends on what else there is going on, and how it's affecting the eye movement function, and of course, whether your vision is affected as well. So lid lacerations, these are quite common. Now they usually are repaired by an ophthalmologist, but mainly if it's affecting your eyelid margin, and that's because obviously when you fix somebody's eyelid, you want the eyelid to be really well aligned, and so that's sort of a bit of specialist expertise that's required. If you've got a laceration that's not affecting the eyelid margin but across the eyelid, you might find that somebody in A&E might be able to suture it up, or somebody from the maxillofacial team. If it's a laceration that's here in the inner corner, then you will always be worried about whether it's also affecting the lacrimal apparatus. And if you've got a canalicular tear, so of course you've got your punctum, which is the little hole in the upper and the lower eyelid that leads to the canaliculus, that leads to a sac in the corner here, and then another tube that leads to the nose and throat to drain your tears. And if you've basically cut through canaliculus, then that may mean that, unfortunately, that your tear drainage becomes impaired. And if it's not fixed, and not fixed quickly, actually, then it could be a long-term watery eye. So definitely something that needs prompt attention if it's a medial canthal area eyelid margin involving lid laceration. So here's I thought I'd put one gory picture in, but here we have, a severe, this is obviously not just front of the eye, this is pretty much, you can see lots of uveal tissue that's exiting. The eyeball is a closed structure, and you open it and things want to come out. When you're doing, for example, a cataract operation, there's fluid constantly inflating the eye that's flowing through. If the fluid comes out, everything wants to come out. You want to always maintain the pressure of the eyeball, and if you've got an open wound into the actual eyeball, then the contents wants to come out. So that's a pretty nasty, horrible injury. But essentially, of course, these need to be dealt with quickly. But you wouldn't want to do too much. You wouldn't want to examine them too much, because it's just all going to come out more. But yeah, so that's that. Here's an example of a blunt injury that's left to a hyphema. So we talked about hypopia. Hyphema is the term we use when there's blood that's settled at the bottom here. And often it's a blunt injury that will cause this. So I don't know, your typical thing that can hit the eyeball would be something like, I guess, like a shuttlecock, or so something that these bands that are used to in to secure luggage, that sort of thing, often will be the culprits that lead to something like a severe blunt injury. But of course, while we've talked about front of the eye, I always want to make sure that the back of the eye is okay. You can get a rupture right through into the back. You can get traumatic optic neuropathy. So, that the impact of something hitting the front of the eye can then sometimes mean that there is some bouncing of the eyeball front and back and pulling against the optic nerve, which is obviously at the back of the eyeball, and that can lead to trauma, which can lead to optic neuropathy. So obviously they're always thinking about the eye as a whole, and often these patients get a lot of inflammation, but the blood will usually settle. Sometimes that blood can then lead to blocking up and inflammation in the trabecular meshwork that can lead to a secondary glaucoma long term. So and some scarring of that tissue. So that's something for a long term thing to consider. Sometimes these patients have great resolution of the blood over a couple of weeks without any further problems, but sometimes they'll get a rebleed. And so with these sorts of patients, you need to always be telling them not to do anything strenuous, to basically not move around too much for a couple of weeks. And usually we keep the pupil dilated, so even the movement of the pupil isn't kind of potentially causing a potential rebleed. If there's a rebleed into the eye, that risk of other problems like the secondary glaucoma become much higher. And usually we treat them with lots of anti-inflammatories like steroid drops to basically get rid of the associated inflammation, the uveitis that comes with a blunt injury like this. So how am I doing for time? I've got 5 minutes. I'm very conscious that... Would you like me to take you through some examination techniques, or does anyone have questions at this point that you want?
So we have about 4 questions that have come through, but if you're okay to run over time a little bit, we can do that also, only if obviously you have the time to do so.
Yeah, no, that's fine. I mean, this is the last bit actually. So it was really just to kind of, so when we're talking about front of the eye examinations, it's obviously not just looking at the eye on the slit lamp, but things like pupils. And I think as a medical student, everyone needs to be able to do those basic things. So a slit lamp is, of course, a biomicroscope, and we use both of our eyes so that we get this good depth perception. And it's difficult to kind of, unfortunately, go through this in a lecture. But of course, hopefully you'll have the opportunity to look through the slit lamp microscope, which is like any microscope really. But you're able to use a slit lamp so that you can look at cross sections through the front chamber and through the layers of the cornea and through the iris and at the lens and so on into the back of the eye. And then we use these Volk lenses, which enable us to then focus on the retina. But front of the eye, we always do this systematically. So if you were asked to, it's always about just being very systematic. So eyelid, conjunctiva, under the eyelid, cornea, layers of the cornea, looking at the anterior chamber, looking for cells, looking at the pupil and so on, looking at the way it reacts, looking at its shape, looking at the lens, and so on. Often in casualty, so whether you're an ophthalmologist or not, you might go and work in main casualty, and they're often seeing patients with a quick look on a slit lamp microscope with nothing too complicated, but maybe just put some fluorescein on the eye. Somebody's come in with a red eye, and I don't know, they think they might have scratched their eye, but they're not sure. And there you have it. Somebody that's got a corneal abrasion just in the center here. And then, of course, if you've left a contact lens in your eye, that will stain with fluorescein as well. So that's sometimes something that people don't realize they've forgotten, and they've got something in, they're not really sure, and that's a retained contact lens. So you do sometimes see that. So everting the eyelid, what you need to do is basically you need to release. So what muscle closes the eye? So, and which muscle opens the eye? It's a different muscle. Does anyone want to offer any?
Is it the levator? Levator that levitates, like opens the eye, right?
Exactly. And which one closes the eye?
That one I forget all the time.
Orbicularis. That's okay. It's kind of like muscle all the way around, and you can squeeze. That's your orbicularis muscle. So you want to kind of basically release the muscle to allow yourself to. So if you say to somebody, look down, then they can't use their levators completely released. So then you can just basically evert the lid. You obviously want them to relax as well, otherwise they're going to squeeze and then they've got a bicularis. But so look down and then you can evert the lid. If you get somebody to look down, it's very easy to lift their eyelid. So sometimes, rather than getting somebody to look up, if you find that they can't do it, you just say, just look down, and then if they're looking down, then it's released and you can do what you want with the eyelid, so it's easier. So that's what we all need to be able to do, is evert the eyelid. Pupil examination. I don't know if you're all already very familiar, but of course we've got our direct and consensual reaction. So you would shine the torch in one eye and then away, and the other eye and away. And what you're looking at is you're looking at not just the eye you shone the light in, but both eyes, because of the consensual response, you should have both pupils constricting exactly the same amount when you shine light into one eye, because of your afferent response. So when you have an RAPD, a relative afferent pupillary defect, what's happening is, although you may be shining a light in one eye, they're not reacting equally. And that's why, does anyone know how we check for an RAPD? Anyone? This swinging light test? Does anyone want to explain it? Perhaps I'll just explain. So basically, you want to, not too fast, but you want to swing the light from one eye to the other, and you don't want the patient. So in this picture, maybe I'm not sure if there's a picture here. There is here. In this picture, so this guy looks like he's actually looking at the other guy, which is not ideal. You want them to look at something in the distance. When you look at something really close, your pupils constrict anyway, because it's part of accommodation. If you're looking in the distance, you kind of want them to be more natural looking, pupil a bit bigger. And then you shine the light in, and you shine it in one eye that said, come away, shine it in the other eye, come away. And you're looking at both eyes to see that they constrict. And then you start to swing across, not too fast, but basically what you're trying to do is to check that as you go to the eye that from the eye that you just shone it into the other eye, that it basically then isn't dilating more. Because if you think about it, if you've got, so there's the afferent pathway and the efferent pathway, and the efferent pathway is obviously coming back and the afferent pathway is going in. But if the afferent pathway has been damaged, so for example, I don't know, you've got an optic nerve, so if you've got an optic nerve damage, you may find that you've got an afferent defect, for example, in advanced glaucoma or somebody that's had some trauma. So when you shine it in the eye, it instead of staying the same small size, it gets a bit bigger. So that's your afferent pupillary defect. I don't think I've explained it very well, so I'm sorry. But I'm sure there's lots of YouTube videos on this as well. But it's important, I think, for all medical students to be comfortable with what a relative afferent pupillary defect is. And of course, you might be asked in examinations to just demonstrate how you check for it. So this is trying to do that. But you see, you've got here efferent, where you've shone it in one eye, and the efferent pathway is the same coming back from both. So both pupils are reacting the same. And then you go from that eye to this eye, and actually it's larger, and it's larger because the efferent pathway the afferent pathway has been damaged. Does that make sense? Well, the afferent pathway has been damaged. Anyway, so here we have another example of something that you may pick up when you're doing a pupillary examination. So here, in a Horner's syndrome, you've got damage to the sympathetic pathway. So, of course, in your fight response, part of your sympathetic pathway will make your pupil dilated. So if you've got damage to your sympathetic pathway, the pupil is smaller. So when you look at this patient and you do, and they haven't got an afferent pupillary defect, but what they have is one pupil in lighting, in all lighting, that may be smaller. But to accentuate it, what you do is you basically have a look at their pupils in darker lighting, because ideally both pupils will dilate. But obviously, if you've got Horner syndrome, the affected pupil won't dilate. But in addition to that, with the Horner syndrome, you may also have a slight ptosis, and you have anhidrosis, which is reduced sweating on that side. Does anyone know of any causes of a Horner syndrome? Anything that may...
Is this the one where you get Pancoast tumor in the lung?
So that's because the sympathetic pathway travels right down here and up. So because it goes into the top of the lung area, a Pancoast tumor may then present with a Horner syndrome. So those people do need investigating to figure out where it is. Is it in the neck? Is it, in the brain? Is it in the Adie's pupil? Has anyone heard of the Adie's pupil? So this is just where some of the iris, the pathway, the nerve supply to the iris starts to be damaged, and that sometimes will happen in diabetics. It will happen in alcoholics. Can happen with trauma, and so you get these patients that have basically asymmetric pupils, and the affected pupil is actually bigger. Over time, though, an Adie's pupil can then start to shrink, so you can end up with a small pupil. But you see these vermiform movements when you look at them on the slit lamp, which is like where it's trying to move, but it's just not. Some of the nerve supply is working, some of it's not. So it's just sort of bigger, and then, as I said, eventually smaller. So we touched on ocular motility when we talked about blowout fractures and orbital fractures. But essentially, we have 6 eye muscles, of course, the 4 recti muscles and the superior and inferior oblique. And so when we do eye movements and ocular motility, we usually want to see whether the eyes are drifting and then see whether the eyes can move. So cover and cover test is basically where you cover an eye, you get them to look in the distance, and you might get them to do it for near as well. Cover eye, uncover eye, cover eye, uncover eye. And then you basically dissociate the eyes by going from one eye to the other eye with your cover. And basically what you're doing is the brain likes the eyes to work together. If one eye is much stronger than the other eye, then sometimes in terms of the vision, sometimes the other eye will drift a bit. And so you may have what we call an ESO or an exophoria, or an ESO or an exotropia. Tropia means it's like this or like this all the time, so they're not working together all the time. But phoria is basically where most of the time your brain can get your eyes to work together. But if you start to dissociate them, you'll start to, the weaker eye may drift, and it might drift out, or it might drift in, and that's a phoria. So, and so that's one part of the test. And then when you're doing eye movements, you might go across and up and down into the 4 corners, and that's looking at all of the eye muscles. And of course, you want them to, look at the target, and often the target is a little torch, actually, because you can often then see, as well as getting them to look at the light, you can see where the reflection is on their cornea. And so sometimes with a very tiny restriction in their movements, you're able to pick it up more easily. And then you might look at more dynamic movements and pursuit and saccades. And so when you're doing pursuit, you're following, and saccades is where you get them to look at something and then the other side. And of course, these things can be affected in various neurological conditions. I won't, I'm conscious of time. And finally, when you're doing eye movement examination, you want to look at convergence. And that's basically, where you bring something close and the eyes come together, and most of us can converge to about 10 centimeters without any problems, and some people have what we call convergence insufficiency. Does anyone have any questions about any of these bits of examination?
No, I don't think so. Are you ready to take any of the questions from the chat?
Yeah.
Amazing. Thank you so much. And thank you for running over time as well. We really appreciate it.
I'm sorry that it's so extensive, but
No, please don't apologise. We really appreciate your time. So we have about, I think, just a few questions. So I'll start with the first one. So this person was asking, so regarding beta blockers, prostaglandins and carbonic inhibitors, which one is best recommended?
So it really depends on what it's for. So if you're treating somebody with open angle glaucoma, often the first line of treatment might be a prostaglandin analog, such as latanoprost. There's so many different ones on the market, preservative-free ones nowadays as well. And that's because what they do is, if you think about prostaglandin, it's a pro-inflammatory thing in a way, isn't it? It comes out channel blood vessels, so those episcleral vessels will open up a bit, and it's quite an effective way as a first line treatment for something like open angle glaucoma. In an emergency situation, where you've got angle closure glaucoma, the first thing you're going to give them is actually acetazolamide, a carbonic anhydrase inhibitor, because what you want to do in that situation is you want to shut off the production of aqueous. And, this is a powerful drug when it's given as an oral tablet. It reduces your potassium levels. It can make you feel quite dizzy. It actually crosses into the blood-brain barrier. So it can also be used to reduce, intracranial pressure. And so but in that situation, you reduce it. In very high pressure, that's where you really need to just get the pressure down. You might be using all carbonic anhydrase inhibitors, but they also come in the form of drops. So you may use them, for example, second line or third line in glaucoma. Beta blockers, of course, are another treatment. So before prostaglandin analogs were around, and they've probably only been around for, I don't know, 20 years, maybe less than that, actually. I think they came, probably less than 20 years. Beta blockers were the first line of treatment, which work both to reduce the production and open up the channel. But of course, beta blockers are going to be contraindicated in somebody that's, I don't know, asthmatic. And if you're already on, if you're an elderly person that's got open angle glaucoma, you're already on a beta blocker tablet form, although there isn't a lot of systemic absorption. These are things you need to be considering when you think of which drug you want to choose. We don't want them to become really bradycardic because, we're overdoing it with beta blockers. So just things to consider. So when we're thinking of open angle glaucoma, we'll use a prostaglandin, then we might, if it's not, everyone is different. Some things work better in some people than other people. You might switch drugs. You might then add drugs. You might have a combined prostaglandin and beta blocker, drop, and so on. So it just depends on the situation. And nowadays, laser treatments are sometimes also used first line or second line, because things like SLT laser is really good for reducing the need to be reliant on drugs. If you tell somebody, I don't know, if they're in their 40s and they've just developed glaucoma, they're going to be on drops all their life, unless if they have surgery or laser treatment or something else. But sorry, a bit long-winded answer.
No, that was great. Thank you so much, Doctor. So the next question is, what is the key differential between acute hyphema and red eye?
So a hyphema is actually where there's been blood inside the eye, not on the surface of the eye. This is inside the eye. Thinking about the front window of the eye, we have the cornea, and then there's the iris, and then, of course, the hole in the iris is your pupil. When you have trauma, what can happen is that the iris blood vessels can, bleed through the trauma, and that will lead to blood inside the front chamber of the eye. It swells around. Eventually, gravity will make it settle. As it settles, that's what we see, which is a hyphema. And what was the difference between hyphema and
red eye?
And a red eye is basically where the conjunctiva, the white part of the eye, has become red. And of course, it can become red for many different reasons. And you've had a whole talk on just red eye because, maybe, the edge of the white bit of the eye, one bit of it's become red because it's episcleritis, or maybe the whole of the eye has become red because it's a conjunctivitis, a more diffuse conjunctivitis, or maybe you've got that circumcorneal injection and that bit of the eye is a red eye because you've got, a uveitis. So, many different forms of red eye, but red eye is the conjunctiva, the episclera, the sclera, the white bit of the eye, where it's hyphema is blood inside the eye. They're different things altogether.
Okay, thank you so much, Doctor. And then the next question was, so in relation to the cornea, which is the most effective and beneficial treatment, contact lenses or laser eye surgery?
Sorry, what was the beginning of the question?
In relation to the cornea.
For what? Are we talking about
Bear with me one moment. Let me try and find who answered this. Sorry, who asked this question. If they're not here anymore, then I will just move on. Sorry, bear with me.
I mean, look, if we're talking about correcting vision.
Yeah, 1 minute.
Yes.
Yes, doctor.
Yep, go ahead.
Yes, I was talking in reference to the cornea, which is the most effective treatment where you have the cornea problem, which we were discussing before. Is it a laser surgery or just the normal treatment with all that conventional treatment? That's what I'm just trying to say.
It depends what the problem is with the cornea. If you've got an infection on your cornea, then you may treat it with antibiotics. If you've got what kind of problem? If you've got an inflammatory problem in your cornea, you might be using anti-inflammatory drops. If you've got trauma to your cornea, you may need to suture up the trauma. If you've got, I don't know, it depends on what the problem with the cornea is. If you're talking specifically about refractive problems, then it's not just the cornea that gives us our refraction. If you think about it, as I said at the beginning, the eyeball is an opaque ball, and there are two windows in the eye. There's the front window, which is the dome-shaped structure called the cornea. There is a second structure which also contributes towards our refraction. That's the lens, which eventually becomes a cataract. So both of those two structures, the cornea and the lens, contribute towards our ability to focus, to see. So what happens is when the light hits the cornea, it is bent. It's directed in towards the back of the eye, and then it hits the lens and it's bent again. And the idea is that the light that hits the cornea needs to basically hit the retina exactly. If it hits in front of the retina, then we say that you are short-sighted and you need a minus lens to basically help the light hit the right place, the retina. If you are long-sighted, it's going beyond that, and we say that you're long-sighted, so your focusing is close. Now, basically, so you need glasses to correct that. If you don't have glasses, you might have contact lenses. And if you don't have contact lenses, yes, somebody might decide to have refractive surgery, or they might even decide to have lens replacement surgery, which is where you remove the natural lens and put in an artificial lens implant. And that's why when you're having cataract surgery, when we remove the natural lens, and we do it because it's cloudy, but it actually is an opportunity to then change your refraction. So there's many, possibilities of how you might change refraction, and it's through glasses, contact lenses. Yes, there's laser treatments, and yes, there's also lens replacement surgery. But I'm not sure that was your question, but basically, I mean, the best way to treat the cornea depends on what the corneal problem is, doesn't it? And the cornea is just one of two structures in the eyeball that contribute towards refraction, towards the optical focusing of light onto the retina, so that the retina can then process that, and hopefully then through the visual pathway, and of course you've got your visual cortex at the back, that then gives us our vision. And the cornea probably contributes about 2/3 of the power, and the lens about 1/3 of the power. But altering both of the shape of both of those, or the power in both of those, will change what our refraction is. But both glasses and contact lenses, of course, glasses are the safest, most risk-free option, I suppose. If that was the question, I'm not really sure. Any other questions?
Yeah, we do have quite a few. Do you have time to take any other questions?
Should we take a few? How many more have we got?
About 3 or 4.
That's fine. Let's try. I'll try and be a bit quicker. Go ahead.
Okay, so the next one is, what is the differential diagnosis between a chalazion and a hordeolum?
Okay, so to be honest with you, they actually mean the same thing. An external hordeolum is actually when the chalazion looks more external. So you can have a chalazion. A chalazion, as I said, is a blocked meibomian gland, and chalazion covers all of those. But when we refer to hordeolum, it's usually because the boil has kind of externalized more. Next question.
Thank you so much, Doctor. So the next question we have is, what is the optimal age for congenital cataract surgery?
So often cataract surgery in babies is done really early, actually, and often it's both eyes quite close to the other. If you do one eye and you don't do the other eye, and they're both called congenital cataract, you very quickly develop amblyopia, which is where the brain preferentially is developing the vision in one eye and really lets the other one go, and that's not good. Often before the age of 2, you'll have removed their lenses. Now, the problem, of course, is that their eyes are going to continue to change shape. So there's a whole sort of, different lecture, I guess, on which lens implant you might choose to put in. And in the past, sometimes these kids would not even have a lens implant put in and then would be wearing these really thick glasses. And then at some point later down the line, they'd have a lens implant put in. I think generally speaking, we try and put lens implants in babies. They usually, as I said, need a primary posterior capsulotomy to remove the back layer of the capsule early. They need lots of support, but early is the answer, less than 2 years.
Thank you so much. And then we have, so how would you examine systematically by using a slit lamp?
So I think we covered that a little bit already, but basically work from the front to the back. So as I said, what's the first thing you see? It's the eyelids. We want to look at the eyelids. We want to look, before all of that, of course, you always look at the person as a whole person. Then you might focus on their face, and then you might get onto the slit lamp and look at their eyelids. And then underneath the eyelids, the conjunctiva, the cornea, the front window of the eye, and then the layers of the cornea. So the slit lamp, the anterior chamber, looking for cells, looking for anything else that's going on, looking at the iris. So it's really literally structure by structure from front to back. Then the lens, that's the front of the eye, and then you may then move into the back.
Thank you so much, Doctor. So we just have the last question. So with corneal transplant, if this affects refraction, is surgery done to correct this? Or is it solely relying on accommodation with glasses, etc.?
So corneal transplants used to be the full layers of all the full thickness corneal transplant, but more and more now, a full thickness corneal transplant, otherwise known as penetrating keratoplasty, is not done so much unless all the layers of the cornea have been affected by the disease. So for many diseases, it's just the front layers of the cornea that are affected, and you might do something called a deep anterior lamellar keratoplasty. The less of the cornea that you replace, the more of your own cornea you still have, and the less there is chance of rejection. Ultimately, also, if you remove the whole full thickness of the cornea, you cut out the whole cornea and you put a new transplanted cornea, you transplant a donated cornea, the full thickness of it, then you are going to change the shape of the cornea. And, there are many techniques for trying to reduce the amount of irregularity in the cornea that may lead to astigmatism and so on afterwards. It really depends on what you're left with afterwards. Sometimes you may do some refractive laser procedures afterwards, but usually patients will then be managed, with glasses and contact lenses. It depends also what the root of the disease was. So, for example, if it was due to scarring from herpes simplex virus, there's a high risk of recurrence of herpes simplex, and the key is going to be about keeping that eye as uninflamed as possible. It really depends on what the original pathology was. A large number of corneal transplants nowadays are actually DMEX or DSEX, which is basically back of the cornea transplant. So you're basically transplanting Decimase membrane and the endothelium, and basically it's because they've got something called Fuchs endothelial dystrophy, or they've developed a dystrophy where the endothelial cells have reduced in number and therefore effectivity. When we look at the cornea, each layer of the cornea has different functions, and the back layer of the cornea, I suppose, is the one that commonly will fail later in life, and that's because the endothelial cells that we're born with are all the endothelial cells we'll ever have. They don't regenerate at all. And so if there's any loss of them, and we're all losing some of them as we age, but if you lose too many of them, the remaining ones kind of spread to fill the space. And the function of those cells is to pump water out of the cornea. And if the action of pumping water out of the cornea becomes less effective, less efficient, the cornea starts to swell. If the cornea starts to swell, the vision starts to become hazy. And, that it's an endothelial transplant or, posterior layers of the cornea transplant is done, I would say, probably most commonly these days. So I think that's it, is it?
Yes, it is. Thank you so much for your time. Such an amazing lecture, so informative. Everyone really, really enjoyed it. So thank you so much. And we'll let you go now and we'll end it there. Guys, if you have anything that you want to say to Miss Amina, then please pop it in the chat or you can unmute yourselves. And yeah, thank you so much.
Thank you, Dr.